Today we'll be discussing the miscellaneous topics in Uvea, that is vascular and degenerative conditions, dystrophies and tumors. So the most common degenerative condition is central serous chorioretinopathy. Earlier it was known as CSR, that is central serous retinopathy. But lately the role of choroid has been recognized in this, and so we prefer it to call CSCR. And that's why I have included this in the Uvea chapter. It is a commonly encountered condition, and we see this more commonly in males. Usually a unilateral condition, can be bilateral. It belongs to a group of conditions known as pachychoroid. Pachy means thick, and choroid is the part of the choroid that becomes thick and causes a lot of manifestations in the retina. So usually associated with high levels of stress, use of corticosteroids, smaller hypermetropic eyes, and type A personality. The disease tends to be self-limiting but has recurrences, and treatment is warranted in some cases. So, what do these patients present to us? They have acute onset of blurred vision with metamorphopsia, which is very important, and they have problem with near vision because the affection is at the macula. You can have micropsia and macropsia, and positive scotoma is always there. So, on examination, visual acuity may be normal or slightly decreased. You can use an Amsler chart to find out the metamorphopsia. And anterior chamber is always normal, but on the fundus examination, you will see a dome-shaped elevation at the macula. So this is the area where the retina has detached. So there is a fluid collection between the neurosensory and the pigment retina. So a 40-year-old woman presents with sudden onset of blurred central vision in her right eye. On examination, retinoscopy reveals +1 diopter in the right eye and emmetropy on the left eye. She denies having any refractive error till date. Amsler charting reveals distorted lines at the center of the chart. What is the next logical step? So clearly we are dealing with a case of central serous chorioretinopathy. The age is fine. There is a hypermetropic shift in the refraction because the retina is elevated forward, and Amsler chart shows distorted lines. So there is some amount of metamorphopsia. So in such cases, the best next step is to perform a good fundus examination, which will help you clinch the diagnosis. Do not give a refractive correction and send her off. You might be missing something that is there in the retina. So we do not need to image these patients. So never image a patient before you do a thorough fundus examination. A patient is diagnosed of central serous retinopathy. The following images belongs to what type of investigation? So all of us know this is an OCT which shows the cross section of the retinal layers. So here if you see this bump, this is the collection of fluid between the neurosensory retina, and this red color is the pigment epithelium, retinal pigment epithelium, and this is the choroid. So if you see directly below the elevation, the choroid is very thickened. See, if you see here, the choroid appears thick in this part. Here the choroid is not so thick. Okay, so this is what we call it as pachychoroid. So when the choroid is thickened, it compresses on the choriocapillaris, and all this imaging is better when you have a swept source OCT or enhanced depth OCT, where you can image the choroid better. Following are the indications of treatment in a case of CSCR. Serous detachment persisting more than 3 months, recurrence of the disease in the eye which has visual morbidity due to the same, FFA showing smokestack appearance, and permanent visual deficit in the fellow eye. So all these are indications to treat. Okay. So smokestack appearance is not an indication to treat because it may be routinely seen in FFA, and FFA is not routinely performed in cases of CSCR. So pick the patterns of CSCR that are seen in fluorescein angiogram. Smokestack appearance, yes, smokestack is, we'll show you the images. Flower petal appearance is usually seen in cystoid macular edema, so this is wrong. Ink blot appearance, yes, this is the right answer. Cardfield appearance is seen in foveal schisis, so this is also the wrong answer. So the answers are A and C. The reason why C came first here is ink blot appearance is a more common finding than the smokestack appearance. So this is how ink blot appearance is seen. If you see, there's a small dot of leakage here, which becomes like an ink blot with time, and the amount of elevation is as big as this. If you can see, this is the CSCR, and this is the site of leak, so which has to be lasered. Okay. So this is a rare occasion of smokestack appearance. You feel with each frame if the smoke is rising. It is not as commonly seen as ink blot. So let's move on to the others. UVL effusion, it is an idiopathic condition which tends to be bilateral, and it's characterized by transudation of fluid from the choriocapillaries into the suprachoroidal space, causing choroidal detachment. So it can also lead to retinal detachment. Other signs of uveitis can be there. So what are the causes of uveal effusion? Inflammatory causes like chronic uveitis, scleritis, and AIDS. Obstruction to the outflow may be due to AV fistula, nanophthalmos, excessive PRP, and uh, if none of these conditions are seen, we label it as idiopathic, which resolves by itself. Chronic choroidal detachment is the detachment of choroid from the underlying sclera. It can be due to serous or due to blood. Let's take a question at this point. All of the following help in differentiating choroidal detachment from retinal detachment. So retinal detachment is separation between the neurosensory retina and the retinal pigment epithelium. Okay, whereas choroidal detachment is the detachment of the choroid from the underlying sclera. So choroidal detachment appears brown. This is true. Retinal detachment appears translucent. So this helps in differentiating the two. So this is not the right answer. This is true. So we have to find the false answer here. Choroidal detachment is associated with the shallow anterior chamber. This is also true. Retinal detachment doesn't need to have a shallow anterior chamber. Choroidal detachment is associated with low intraocular pressure, where retinal detachment is associated with. This is a false statement because RRD or rheumatogenic retinal detachment usually might have a low intraocular pressure. Choroidal detachment is bounded posteriorly by the entry of vortex veins, whereas retinal detachments may occur as any part of the retina. This is also true. The right answer here is C. Okay. So retinal detachments appear translucent. The choroidal detachment appears brown. Then choroidal detachments usually are associated with a shallow anterior chamber and a low intraocular pressure. So choroidal detachment can be due to serous fluid or a bleed. So it can be a serous choroidal detachment or a hemorrhagic choroidal detachment. The causes of serous choroidal detachment are hypotonia that may follow trauma or surgery or inflammation. During intraocular surgery in glaucoma, chronic glaucoma, usually uh, when you operate on a eye with very high pressure or long-standing glaucoma in very elderly individuals, there is severe arteriosclerosis. So when the globe is opened, so these arteries might burst and bleed into the suprachoroidal vessels. So the source of blood is usually the long posterior ciliary arteries, and they bleed very profusely as it is an arterial blood. Okay. The symptoms are diminution of vision. In hemorrhagic choroidal detachment is severe throbbing pain. On examination, you'll see shallow anterior chamber with very low high IOP, in contrast to hemorrhagic choroidal detachment, which has very high IOP. Fundus will show dome-like elevations limited by the vortex veins. Here you see peripheral dome-like elevations with the loss of glow. The fundus glow is lost, and the B scan will show kissing choroidals. This is a serous choroidal detachment is a self-limiting condition which can be treated with the topical steroids and cycloplegic. Sometimes you can even use oral steroids. If it remains there for more than a week, then you can think of sclerotomies and drainage of the fluid. But for hemorrhagic choroidal detachment, it is an emergency. You have to close the wound, maintain infusion into the anterior chamber, and make sclerotomies to drain the blood. So it might even require evisceration as the blood can bring out all the contents of the eyeball. It is a dangerous condition. So coming to degenerative conditions of the uvea, you have central areolar choroidal atrophy, which is characterized by bilateral punched out circular atrophic lesions, usually in the macula. Usually, the underlying sclera becomes visible. This happens due to degeneration of photoreceptors, RPE, and the choriocapillaris. Whereas gyrate atrophy is an inborn error of metabolism due to the absence of ornithine aminotransferase. So, as a result, there is accumulation of ornithine in the RPE, and you see this beautifully scalloped edge of uh, atrophy of the peripheral in the peripheral retina. When the disease progresses, these atrophy progresses more towards the posterior pole. These are sharply demarcated circular lesions. Okay, very characteristic of gyrate atrophy. These patients present with nyctalopia and myopia. Arginine-free diet is helpful. So degenerative conditions of uvea, the third important one is choroideremia. It's an X-linked recessive genetic disorder affecting males characterized by diffuse choroidal atrophy. So in choroideremia, you have in choroideremia, there is the patients usually present with nyctalopia, and then slowly it progresses to complete loss of vision. Fundus findings include whitish patches of the choroidal and RP atrophy with white sclera and overlying normal retinal vasculature. You see that the normal retinal vasculatures look as if they are hanging on the bare sclera. So coming to tumors of uvea, uveal tumors, melanomas are the most common ones. It can be arising from the iris, ciliary body, or the choroid. So iris melanomas are usually seen as flat or mildly elevated lesions in the pupillary area with disruption of the iris structure. It is a low-grade malignancy mainly composed of spindle cells, and it presents usually in the fourth or fifth decade, a little earlier than choroidal and ciliary body melanoma. It may be associated with pupillary abnormalities such as ectopia and uvea, and these lesions may be spread through the angle. The treatment depends on how much of the iris is involved. So, sector iridectomy is performed for smaller tumors. If the tumor is large and invading the angle, you have to perform a iridocyclectomy. So, if it's a rapidly growing tumor which is posteriorly progressing, enucleation is advised. Coming to ciliary body melanomas, they may present in different ways because the ciliary body is not really visible on the slit lamp examination. You might have to look for some clues, like local episcleral vessels may be dilated, and this is known as sentinel vessels. The tumor may extend through the root of iris. The tumor may impinge on the lens and cause astigmatism. The tumor may perforate the sclera and present as an epibulbar mass. It can cause anterior uveitis due to tumor cells seeding the trabecular meshwork. Then exudative retinal detachment can be there due to posterior segment extension. And ring melanoma is defined as a circularly growing melanoma, and it has very poor prognosis. Treatment is iridocyclectomy, usually for tumors involving more than one-third of the angle circumference. Brachyradiotherapy and enucleation may be required in larger tumors. Coming to choroidal melanomas, these are more common primary intraocular malignancy in adults, usually seen in the elderly in the 7th or the 8th decade. It usually presents as a solitary tumor and is usually unilateral. It may present as a solitary tumor arising from the choroid and entering the subretinal space through a small breach in the Brooks membrane. So this appearance of the tumor is known as collar stud because there is a small extension between the choroidal part of it and the subretinal part of it. So lipofuscin is commonly seen on the surface of the tumor, which helps in identifying it. Histopathology, it can be three types: spindle cell, epithelial cell, and mixed variant. Spindle cell have a good prognosis. So what is the treatment? Which of the following is best suited for the treatment of the choroidal melanoma, that is less than 5 mm thick and less than 5 mm broad? So depending on the size of the melanoma, we can have different treatment options. Earlier we had only enucleation as treatment option, but now we have a lot of options. So the right answer here is brachytherapy. Let's see why. Tumors less than 20 mm breadth and 5 mm thickness, there is a chance of salvage emission. Okay. And the side effects of brachytherapy include cataract, maculopathy, retinopathy, and papillopathy. Then other ways in which we can treat smaller tumors with posterior location are proton irradiation, transpupillary chromotherapy, transscleral choroidectomy, and enucleation is mainly reserved for larger tumors with optic nerve involvement in which vision cannot be salvaged. Excitation is required in orbital involvement, and you need systemic chemotherapy for systemic metastasis. So this is all about Uvea. Thank you.